Okay, so we are live on the first session of 2025. First of all, Happy New Year, everyone. To our audience, to the doctors, to our presenter, and to all the CMAAO countries. Wish you a very Happy New Year, and may whatever news we are hearing, I believe we just have a healthy New Year. Uh, uh, and I also like to remember Dr. K.K. Agarwal on this day. It's the first day of the year. Because of him, we are having this session. And I personally been associated to a medical field where I'm not a medical doctor. So I thank Dr. Monica, I thank Dr. Sajjad, Dr. Akhtar Hussain, Dr. Angelique, uh, and Dr. Dravid, who is here for presenting our first session. We have Dr. Gute from Maharashtra, Dr. Tiwari, and many other doctors present here. Today, we are talking about HIV. We have Dr. Ameet Dravid. He's a chief consultant in HIV medicine and infectious disease from Ruby Hall Clinic, Noble Hospital, Pune Hospital, Medical Research Center, Pune. He's an MT in internal medicine and having more than 12 years of experience in clinical care and treatment of HIV infection individuals in 3 private sectors. He's a member American Academy of HIV Medicine, member AIDS Society of India, member International AIDS Society, member European AIDS Clinical Society. He's here to present a very important topic, understanding HMPV risk, precautions, and insight. Over to you, sir.
Thank you, Saurabh, and my deepest regards to Dr. K.K. Agarwal, and thank you for the platform for idea exchange which you have given me. I'll share my slides now. Can you see my slides?
Yes, sir, we can see. Just make it on the presentation mode.
Yeah.
Thank you.
So today morning we will be talking about HMPV, human metapneumovirus, risks, precautions, and insights. And why are we discussing this in India and all over the world? Because of social media. The disease has created quite a social media stir, because there were reports saying that hospitals in China, nursing homes in China are completely full with patients suffering from human metapneumovirus. So it was essential for the government of India as well as governments all over the world to educate physicians to know what is the real scenario going as of now. So just to understand the real scenario, I just went to the Chinese CDC website. And remember, Chinese CDC website updates itself every week. So what do the Chinese authorities say? They have acknowledged that human metapneumovirus cases are increasing in some parts of their country, especially the north of China, emphasized that the virus is a known entity and the diseases are not unusual for this time of the year. So it's not a new virus. There are reports circulating that this is a new virus, it is going to cause havoc. Again, we are going to see equivalent of what we saw in COVID. But remember that this is not a new virus. The virus is a new known entity, and that disease patterns are not unusual for this time of the year. Every time in December and January, China does get a respiratory surge. China has a robust respiratory pathogen surveillance system, and it is reported transparently on a weekly basis. The latest results of China's CDC show that the respiratory surge is actually occurring because of 4 viruses. Influenza virus, which is H1N1, or the swine flu as we call it in India, rhinovirus, respiratory syncytial virus, and human metapneumovirus. So the respiratory surge or the viral upper respiratory tract infections increasing, or lower respiratory tract infections increasing in China, northern part of China, are because of 4 viruses. It's not because of one virus alone. 4 viruses are responsible for this respiratory surge. And nationally, the main cause for outpatient influenza-like illness and hospitalized severe acute respiratory infection is actually H1N1. So they are clearly saying that we are actually having a respiratory surge because of H1N1. while other three viruses, rhinovirus, respiratory syncytial virus, and human metapneumovirus, are also being seen. The problem is we have just picked up this one virus and run with the news saying that this is some new virus. It is not a new virus, it's a known entity. Along these months, every year, these disease patterns are seen. But yes, we definitely need to educate ourselves about this new virus, which we were not talking about much, that is human metapneumovirus. What does WHO say about the HMPV situation in China? WHO has released clear information and they confirm what is being seen as would be expected for this time of the year. So this winter surge was expected. There is no unusual outbreak pattern. The healthcare system in China is not overwhelmed. There is no lockdown going on in China. Flights in and out of China are normal. People are going about their business normally. So yes, there is a winter surge of viral upper respiratory tract and viral lower respiratory tract infections because of 4 viruses: influenza, respiratory syncytial virus, rhinovirus, and human metapneumovirus. We will talk about human metapneumovirus today, but we don't need to be worried because this is just a routine winter surge occurring in China. So what do we know about this virus? In 2001, a new virus was detected, which was known as and designated as human metapneumovirus. It was identified by Dutch investigators. However, they also say that this virus is in circulation for almost 60 years with worldwide distribution. So there is worldwide distribution of human metapneumovirus. It is a large enveloped negative sense RNA virus. It's an RNA virus, just like COVID was. It has 2 clades, A and B, out of which there are multiple subgroups. There are 4 subgroups of viruses circulating, A1, A2, and B1, B2. There is no correlation between HMPV subtype and clinical outcome. So more or less, they are equally bad or equally good. We don't need to worry about it. It circulates in late winter through spring. So Jan to March is the time when you normally get infections with respiratory viruses, influenza, respiratory syncytial, and also human metapneumovirus. So it is not a new virus. In India and in Pune, where I work, every year the National Institute of Virology Pune does report few cases of human metapneumovirus every year during this time. So we don't need to really get alarmed that a new virus has been introduced into the world. A new virus is not getting introduced in the world. So you can see here seasonality of human metapneumovirus infections. These infections rise from Jan to April. So we are in Jan in India. In the northern hemisphere, Jan to April is the time when maximum number of human metapneumovirus cases are seen. So it's quite likely that some amount of human metapneumovirus infections reporting will increase in the northern hemisphere, including India, and we will be prepared for it. What is it? As I said, this is the virus, 150 nanometer virus. It is an RNA virus. It has a nucleocapsid and an envelope, and these are the fusion proteins which help the virus to get into the cell and cause problems as it does. It is a close sister virus of respiratory syncytial virus, which we know causes upper respiratory tract infections in children and also causes severe pneumonia in children less than 5 years of age. So if you look at the genome of human metapneumovirus and respiratory syncytial virus, in fact, both these viruses were categorized in the family of paramyxovirus some years back. 20 years later, a new family was created for these 2 viruses, which was known as the pneumovirus family. The human metapneumovirus belongs to the metapneumovirus family, while respiratory syncytial virus belongs to the same family of viruses, which is pneumovirus. What is the difference in the genome? You can see only human respiratory syncytial virus has 2 more genes. NS1, that is non-structural protein 1, and now non-structural protein 2. So 2 extra genes, more or less the genome of respiratory syncytial virus and human metapneumovirus is 90 to 91% similar. So if we know that respiratory syncytial virus is there since ages together, we have to agree that even human metapneumovirus has been there since 60 years, although we have named it only 20 years back. So it's not a new virus. It is routinely seen in these months. January to March is when the respiratory surge occurs. It is not a virus which is getting introduced newly into our population, and hence I feel that pandemic potential or epidemic potential of this virus is very, very low. And hence the overwhelming of the healthcare system is very, very unlikely, because more or less we have some amount of immunity to this virus. How? I will explain in my next slides. So this is the distribution. You can see the subgroup A2 has been reported from India before as well. So we have been reporting, the National Institute of Virology, Pune has been reporting this virus since last many years to the world, and subgroup A2 is what is prevalent in India, and these are the subgroups which are prevalent all over the world. How does it transmit? It's a respiratory virus. So because of direct or close contact with contaminated secretions, a person who has viral upper respiratory tract infection, who has fever, cough, cold, is coughing incessantly, is going to transmit. And if you come in close contact with contaminated secretions, then you will get infected with the virus as well. It involves large particle aerosols, droplets, or fomites, but not small particle aerosols. And that's why physical separation more than 6 feet will interrupt the aerosol transmission. We have known about physical separation or social distancing more than 6 feet during the COVID-19 pandemic, which was also a respiratory virus, which was also transmitted by respiratory secretions. So physical separation will interrupt transmission for this virus as well. Second way of transmission is in the hospitals. Nosocomial infections have been reported in hospitalized children, because this virus, if you get a patient with human metapneumovirus infection admitted in your hospital, it needs isolation for the same reason. Especially in pediatric hemato-oncology wards, nosocomial transmission from one child to another has been known. We have our patients, a lot of elderly patients in India are in skilled nursing facilities or home care. In such facilities also, nosocomial transmission from one patient to another has been reported. Large-scale HMPV outbreaks of severe LRTI in residents of long-term care facilities have also been reported. So this virus is transmitted because of contaminated secretion, because of incessant coughing, and nosocomial transmission among children and elderly adults is also known. What is the incubation period? About 5 to 9 days. So once the virus is inoculated in your respiratory tract, you will have an asymptomatic period of about 5 to 9 days, after which the symptoms will start. As I said, virus is ubiquitous. It is there since last 60 years. There have been 14.2 million human metapneumovirus associated acute LRTI in children less than 5 years of age in 2018 have been reported. Because in India and in the middle and low income countries, the reporting system is not robust. That's why we just label them as viral LRTI. But if you assign a viral etiology to that LRTI, I'm sure human metapneumovirus acute lower respiratory tract infections in children in India will also be reported on a large scale. What is the annual incidence of hospitalization though? Out of 10,000 children, you will have only around 2 pneumonia hospitalizations, and that too in the youngest age group, less than 2 years of age, the maximum number of hospitalizations will be there. What about adult hospitalization? Out of 10,000 adults, only around 2 hospitalizations will happen, and that too in the oldest age group it will happen. So remember, out of 10,000 infected patients, children, only 2 will be hospitalized. Out of 10,000 infected adults, only 2 will be hospitalized. So it is not a disease which sends you to the hospital very, very frequently. It's not like COVID-19 that our healthcare system is going to be overwhelmed. Yes, you will get viral upper respiratory tract infections. Some children might need get admitted, especially our elderly above 75 years of age. They need to be careful. They might suffer from viral upper respiratory tract infection. They might also land up in hospital as well. What is the seasonal variation? I've already explained, late winter and early spring in northern hemisphere. And remember that after emergence of SARS-CoV-2 for 1 year, when we were practicing social distancing, universal masking, hand washing, that time, not just the emergence of SARS-CoV-2 decreased, but the emergence of other respiratory viruses like HMPV also decreased. So what we did for COVID-19 does work for prevention of HMPV and other respiratory viruses as well. So we don't need to worry. Only very, very young children and elderly adults are at risk of this virus. So you can see here, February, March, influenza, corona, respiratory syncytial, and human metapneumovirus. These are the 4 viruses which will flare in the northern hemisphere. while in November, December, it will be only influenza and respiratory syncytial virus. So we have just passed December. That time we did not get a human metapneumovirus flare, but we might get it in India if we start testing all samples of viral URTI or viral LRTI in our country. The problem with our countries is less testing because we are low and middle income countries. In the States, in Europe, every pneumonia case they try to get to a diagnosis, because of which they can identify that so many human metapneumovirus infections have already occurred in the world. 14.2 million children got infected just in 2018. So you can see how many. Remember, the first infections occur early in life. So by age of 5 years of age, 100% of children will get their first infection with human metapneumovirus infection. So it's mostly a child-related illness. Up to 5 years of age, all our children will have got human metapneumovirus infection. We might not have even realized it. It's a viral upper respiratory tract infection. It's self-limiting. Many times children don't even go to a doctor. Many times it does not get even tested. And hence we don't know about this virus. But this virus is there. It is affecting our children every year. And by 5 years of age, 100%, almost 100% of children will be infected at least once with human metapneumovirus. In studies of children with acute respiratory illness, around 5 to 15% of children will require hospitalization. They will develop viral lower respiratory tract infection, especially in infants less than 1 year of age. So there are certain risk factors which can land a child in the hospital because of viral lower respiratory tract infection because of human metapneumovirus. What are the factors? Age less than 6 months. So premature babies, babies who are born premature, female sex, genotype B infection, and very, very young infants less than 1 year of age who have been born premature. They have poor immunity. They can't tackle it. If they develop the viral infection, then they can land up because of viral lower respiratory tract infection. So don't worry, almost all our children have had this infection and they have already received the first infection. They have already developed immunity by age of 5, 100% of children. As I said, hospitalization is more common in children who are premature, children who have prior history of asthma. These are the comorbidities which can land up your children in the hospital. Children may require supplemental oxygen. There can be dyspnea, there can be wheezing, and hence we need to be vigilant when children develop wheezing, children develop tachypnea, children land up in hospital, especially those who are less than 1 year of age. We should be testing their samples for human metapneumovirus. Human metapneumovirus could be an infection of viral LRTI in India, and very rarely it can cause fatal respiratory illness in children as well. As I said, the simple symptoms in children: cough almost 90%, rhinitis around 44 to 77%, fever around 80%, wheezing. These are the 4 symptoms very commonly seen in children less than 5 years of age. Upper respiratory tract infection also includes rhinopharyngitis and laryngitis. If the child develops lower respiratory tract infection, commonly it involves bronchiolitis, croup, exacerbation of asthma, and very rarely pneumonia. So this virus very rarely causes pneumonia. Lower respiratory tract infection mostly involves bronchiolitis, croup, and exacerbation of asthma, because of which the patient will develop severe wheezing, severe tachypnea, will require oxygen, will require hospitalization. But many times the X-ray or the CT scan might be completely normal. So pneumonia as a lower respiratory tract infection feature is very, very rare in children because of human metapneumovirus. So majority hospitalizations are because of acute bronchiolitis. Remember, human metapneumovirus is a sister virus of respiratory syncytial virus, and many times co-infection of human metapneumovirus with respiratory syncytial virus is common. And if there is co-infection in children, there is a 10-fold increase in need for mechanical ventilation. So severe bronchiolitis, severe wheezing can land up your child on the ventilator as well, especially if there is co-infection with respiratory syncytial virus. But remember, the incidence is very, very low. 2 pneumonia hospitalizations in children per 10,000 infections. So it's not so easy for human metapneumovirus to land up your child on a ventilator. But yes, majority of the children will be affected by 5 years of age. There have been studies amongst HIV infected children that giving pneumococcal vaccine to HIV infected children has reduced HMPV related lower respiratory tract illness as well, which could suggest that HMPV and bacteria like Streptococcus pneumoniae, H. influenzae can work in tandem to cause severe pneumonia in children, especially premature child, especially child with asthma can get infected with HMPV and bacterial co-infection as well. Very rarely HMPV does cause severe acute encephalitis also in children, and very infrequently it has been associated with sepsis syndrome in infants. So yes, complications do occur, pneumonia does occur, but very, very rarely. Majority of the time, the lower respiratory tract involvement in children is bronchiolitis, wheezing, breathlessness, and need for oxygen. And up to 5 years of age, all children will have at least one episode of HMPV infection. So this virus is not new. All our children above 5 years of age have had one episodes. We don't need to worry. They have already sometimes maybe transmitted the infection to adults as well. What is the epidemiology in adults? It normally causes upper respiratory tract infection in adults. Frequency of lower respiratory tract illness appears lower than in children. So adults, as I said, most of the times it is a child-related disease less than 5 years of age. But yes, our frail, older adult patients with HMPV infections are most likely to require medical care. So our elderly population above 65 years of age is at risk of human metapneumovirus infection, and then there they can cause viral upper respiratory tract infection, viral lower respiratory tract infection, and they are the ones who will require medical care. Remember, almost 77 to 10 crore people are above 65 years of age in India, so it's a sizable population, and if they do get human metapneumovirus infection, we will have to care for them. So because of the size of our country, the population of our country, although the incidence of hospitalization and incidence of lower respiratory tract illness and complications is low in human metapneumovirus infection, we might have certain cases which we will have to attend to. What are the clinical manifestations? Then human metapneumovirus in adults, as I said, mostly a mild self-limited respiratory infection. The incubation period is around 5 to 9 days. So there might be an asymptomatic period followed by weeks, a week of upper respiratory tract symptoms, and then there will be gradual resolution. The peak of virus shedding is about 1 week after inoculation. So symptoms also follow that. Symptoms likely follow a day after peak shedding. So if day 7 is the day of peak shedding, the symptoms will start maybe on day 8 and will last up to day 15. In severe disease, there is a brief asymptomatic period of day or two following upper respiratory tract symptoms, and then wheezing begins and other signs of lower respiratory tract involvement starts. So if the virus is inoculated in your upper respiratory tract, maybe an asymptomatic period of 7 days, followed by upper respiratory tract symptoms for 7 days, then a lull of 2 days, followed by lower respiratory tract involvement with wheezing and pneumonia and other things starting. Individuals with a predisposition to reactive airway disease are asthma patients, are COPD patients, are post-tuberculosis patients, are patients with smoking-related lung disease, are patients with interstitial lung disease or idiopathic lung fibrosis. All can develop recurrent mild wheezing and cough for days or even several weeks. So it can cause upper respiratory tract infection, it can cause lower respiratory tract infection. Once it goes to the lower respiratory tract, it can cause wheeze and cough for days on end. Hospitalized patients are most commonly are bronchiolitis or asthma exacerbation. As I said, just like in children, pneumonia and ARDS in human metapneumovirus infection is rare. So what are the symptoms? Cough, nasal congestion, rhinorrhea, dyspnea, hoarseness, and wheezing. Fever is a very infrequent symptom of human metapneumovirus infection. Most of the time, cough, nasal congestion, and rhinorrhea, followed by wheezing and dyspnea, are the most common symptoms. What about recurrent infection? Remember, whatever adult infections we are seeing are recurrent infections only. Why? Because all our children are affected in the first 5 years of life. That is the first infection they are getting. So all adult infection represent reinfections. Majority of the reinfections are mild. I've already said it's a mild viral upper respiratory tract illness in majority of the patients. Even in adults, around behind every 10,000 adults, you will have 2 hospitalizations. However, immunocompromised patients, elderly patients, frail elderly adults in long-term medical care facilities, they are at risk, and they are at risk of severe disease during reinfection, And we need to concentrate on that age group and that class of patients to identify whether there is a human metapneumovirus surge happening in India from January to March. Just like influenza virus, this virus also undergoes antigenic drift, but the mutations which it accumulates are not sufficient enough to give it any pandemic potential. And that's why I said I don't envisage a pandemic of HMPV occurring in India or in Southeast Asia anytime soon. I don't think that our respiratory wards or our hospitals are going to be overwhelmed. I don't think that there is going to be sudden scramble for oxygen and ventilators. We are well equipped to handle this surge, which is normally occurring in China. And if it occurs in India, it will be related to climate related issues because of the cold and the low temperatures in India as of now. And we don't need to worry much. Yes, we need to be cautious about this virus. Then come the immunocompromised hosts. What is the problem occurring in immunocompromised hosts? Human metapneumovirus infections can be especially severe in immunocompromised patients because of poor clearance of the virus. Which category of immunocompromised patients are affected? As I said, hematologic malignancies and hematopoietic stem cell transplantations are the group which is most affected. There was a study of almost 428 hematopoietic stem cell transplant recipients who showed human metapneumovirus upper respiratory and lower respiratory tract involvement. The study found that if you have lymphopenia and you are using corticosteroids for more than 30 milligram per day, then it's the biggest risk factor for lower respiratory tract disease. Overall mortality was 2% in immunocompromised host with upper respiratory tract disease, while it was a staggering 21% if these patients develop lower respiratory tract disease. So remember, our patients with hematologic malignancies, those who are acute myeloid leukemia, acute lymphoid leukemia, multiple myeloma, aplastic anemia, myelodysplastic syndrome, hematopoietic stem cell transplant, allogenic transplants, all these are at very, very high risk of human metapneumovirus infection. If it occurs to them, then they will develop upper respiratory tract. Sometimes they can develop viral lower respiratory tract involvement like bronchiolitis, pneumonia, ARDS, and they can then land up on a ventilator and can get serious. So they really need to be protected against this virus. Multiple times there are co-infections happening, and then co-infections can be viral, bacterial, or even invasive fungal infections. And I'll show it in my next slide. So this was the study which was published about 428 hematopoietic stem cell transplant recipients with human metapneumovirus infection. And that's what it said, that the peak of this infection, even in bone marrow transplant recipients, was March and April. Lower respiratory tract involvement was occurring in a staggering 40% of cases with stem cell transplant. Overall mortality was as high as 37% in proven lower respiratory tract illnesses. Co-infections were frequent, especially with influenza virus, respiratory syncytial virus, rhinovirus. So all these respiratory viruses which are circulating from January to March can have these issues. Corticosteroids, if the patient is on, and lymphopenia are the main risk factors for lower respiratory tract disease, hospital admission, oxygen requirement, and mortality. And this goes to show that it is the T cells which are responsible for protection from human metapneumovirus or any other respiratory virus. And if the T cell immune response is blunted because of myeloablative conditioning regimens for hematopoietic stem cell transplant or steroids, then clearing of this respiratory virus becomes difficult. And this leads to these respiratory viruses like human metapneumovirus going from upper respiratory to lower respiratory tract and causing problems. As I said, efforts should be limited so that T cell immune reconstitution can occur early after allogenic human hematopoietic stem cell transplant, and that is the only way we can control pneumonia from occurring in these patients. So this was the study. You can see if your lymphocyte count on bone marrow transplant is less than 500, you are using steroids, you are having active graft versus host disease, then your risk of developing hospital admission, oxygen support is very, very high. Even mortality is high in patients who have lymphopenia and corticosteroid usage. So these are the ones we need to guard. And we have a huge population of hematologic malignancies in India. We have a large population of patients requiring hematopoietic stem cell transplants, and they need to be protected. Our elderly above 65 need to be protected. Our elderly in long-term care facilities need to be protected. These are the ones we should be concentrating on. And that's why I feel that every day putting out numbers of patients developing human metapneumovirus infection is useless. because it is just adding to the panic. 8 cases here, 7 cases there. We should be just putting out cases who developed severe disease because of human metapneumovirus. And I'm sure that as of now, we don't have even a single case of severe human metapneumovirus infection landing up on a ventilator. Yes, we should be testing a lot of people, but only those with severe disease because of human metapneumovirus should be reported. As I have said, there can be co-infections in the lung with human metapneumovirus, especially in immunocompromised patients. We can have co-infections with coronavirus, respiratory syncytial virus, which I talk about in my next slide because it's also a sister virus. There can be influenza co-infection, and then there can be bacterial co-infections as well. So pneumonia, which can be viral plus bacterial, like Pseudomonas or Strenotrophomonas, E. coli, Staphylococcus, Streptococcus. All these bacteria can coexist along with human metapneumovirus. And if you have a viral bacterial co-infection, then the oxygen support is going to increase. Maybe the mortality and prognosis can also worsen. Fungal infections are also known. Just as you said, with COVID-19, we had epidemic of invasive aspergillosis, invasive pulmonary aspergillosis. Similarly, with human metapneumovirus, we can have concomitant pulmonary aspergillosis. And if we get such cases where our immunocompromised host has human metapneumovirus pneumonia, then we should be looking for concomitant invasive pulmonary aspergillosis as well, because that is going to change the prognosis of your patient. You can see here, mortality if in upper respiratory tract illness only is very, very low, but almost 38% people have lost their life in proven lower respiratory tract involvement because of human metapneumovirus. So it's not a dangerous virus for normal individuals. It is not a dangerous virus for children. It is not a dangerous virus for immunocompetent adults, but it is a dangerous virus for premature babies, babies with asthma, elderly with above 65 years of age, elderly living in long-term care facilities, hematologic malignancies, and hematopoietic stem cell transplant recipients. What are the other immunocompromised hosts which need to be protected? Remember, progression of the disease from upper to lower respiratory tract illness was higher in HIV infected patients who were not on antiretroviral therapy. So if you are HIV infected, please ensure that you have a good CD4 count, because the T cell is what is going to protect you against the human metapneumovirus infection. Lung transplant recipients are also the ones who can develop severe human metapneumovirus infection, and the severe infection can lead to lung allograft dysfunction within a year. So lung transplant recipients are also the other category of transplant recipients which are at high risk of severe human metapneumovirus infection, and we need to be careful. If such patients develop fever, cough, cold, or breathlessness and wheezing, we need to test this. How do we diagnose it? The diagnosis, unfortunately, is only by PCR, and we don't have a human metapneumovirus specific PCR test as of now available in India. Although certain labs in Pune are putting out advertisements saying that we can test for only human metapneumovirus RT-PCR, whether they are validated or no, I don't know. But there is one test, which is the BioFire Film Array Respiratory Panel Assay, a multiplex PCR panel, which is there available in most of the private hospitals in metro cities in India. This is a multiplex PCR test where we send nasopharyngeal swab samples of patients developing fever, cough, cold, or we can even send sputum and bowel samples of patients with lower respiratory tract involvement. This BioFire test, upper respiratory tract test or lower respiratory tract panel test, can detect human metapneumovirus infection along with other viruses like influenza, corona, adeno, parainfluenza, respiratory syncytial virus. So it's a package test where other viruses along with certain bacteria and fungi will also be identified, and this test is available in India, and I'm sure it's available in Southeast Asia, in other countries as well. So this is the only test which can pick up human metapneumovirus infection in upper respiratory and lower respiratory tract samples. What about serology? We don't have a serology and it is not validated for testing. So human metapneumovirus IgG, IgM is not a test which we normally recommend. What about imaging? Imaging is non-specific. It is non-specific because it can mimic any other viral pneumonia. It can mimic pneumonia because of COVID-19, pneumonia because of H1N1, pneumonia because of respiratory syncytial virus. And most commonly, we see perihilar opacities, hyperinflation, atelectasis, and occasionally consolidation. So I have said that it normally causes bronchiolitis, wheezing, and asthma. Very rarely consolidation, but sometimes consolidation can be seen. So this is a classical feature of human metapneumovirus infection, where reticulations and ground glass haziness which is non-specific and can be seen in any viral pneumonia. So it is very difficult to distinguish on imaging the difference between human metapneumovirus and other viral infections. So you can see this was a good paper which showed imaging findings in other viral illnesses, and it showed that normally corona or COVID-19 doesn't cause centrilobular nodules or tree in bud appearance, while RSV and influenza and human metapneumovirus can cause centrilobular nodules, micronodules, or tree in bud opacities. However, ground glass opacities and consolidation can be seen in all other viral illnesses. So very difficult to differentiate between the etiologic agent of viral pneumonia just by looking at the CT. What about treatment? Ribavirin is one antiviral drug which can have in vitro activity against human metapneumovirus. The rate of secondary bacterial infections is very low, and hence antibiotics are not indicated. But as I've already said, majority of the patients are going to have mild, self-limited viral upper respiratory tract infection, and they can be given routine cough cold remedies. So whatever we use for treating common flu, nasal decongestants, paracetamol, that will be sufficient in managing majority of the respiratory tract infections cases because of human metapneumovirus. Ribavirin will be required only in exceptional circumstances, that too in immunocompromised host with severe viral pneumonia, where such routine decongestant remedies are not working. So there have been case reports where in severe human metapneumovirus infections in patients with stem cell transplants, they have used IV ribavirin plus immunoglobulin, IVIG, which we, as we normally say in India, and successful treatment of pneumonia has occurred. But the use of ribavirin and IVIG is going to be very rarely needed. Majority of the time, routine cough cold remedies, decongestants, and paracetamol is going to help the patients with pneumonia. What about infection control? It is likely that transmission of human metapneumovirus is by direct or close contact with contaminated secretions, and whatever we achieved with COVID-19, the same contact precautions can be used for hospitalized patients as well. Those who require hospitalization because of human metapneumovirus should be cared for in single rooms or in cohort of human metapneumovirus. So universal masking, social distancing, hand washing, keeping, if you have cough cold, then not going outside and mingling with the crowd. These infection control measures which we utilized during COVID-19 pandemic, the same thing can be utilized for human metapneumovirus as well. So the prevention routine remains the same. Broader use of mask, even our normal triple layer mask is enough. Cloth masks are also enough. And remember, there have been studies that widespread use of mask during the COVID-19 pandemic actually brought down transmission of other respiratory viruses like RSV and human metapneumovirus as well. So we don't need to worry. We need to be just concentrating on prevention measures. I'll talk briefly about respiratory syncytial virus because these two viruses go together and we cannot differentiate the two. As I said, there are only two genes which differentiate between respiratory syncytial virus and human metapneumovirus, and respiratory syncytial virus is a bigger problem in children and in adults than human metapneumovirus. Even in China, the respiratory surge which has happened for 4 viruses: influenza, respiratory syncytial, human metapneumo, and rhinovirus, and hence we need to know about it. As I said, even in respiratory syncytial virus infection in adults, less than 1% of adults are going to require hospitalization. But still, in United States, because they test every viral upper respiratory tract infection for the etiologic agent, they have found almost 160,000 hospitalizations and around 6,000 deaths among adults above 65 years of age. So just like human metapneumovirus, even respiratory syncytial virus does affect children less than 5 years of age and adults above 65 years of age. Especially the risk is high when your age increases more than 75 years of age. Also, if you have comorbid conditions with the lung and the heart, especially asthma, COPD, congestive heart failure, then you can fall prey to respiratory syncytial virus, lower respiratory tract infection as well. As I said, the risk of hospitalization of these two viruses is higher in patients with congregate living facilities, especially nursing homes or long-term care homes where our elderly are sitting. And there, almost sometimes 10 to 31% of patients have required, those who get hospitalized because of RSV have required intensive care admission. Almost 17% have required mechanical ventilation, And why is it important? That the risk of invasive mechanical ventilation because of respiratory syncytial virus is 1.5 times that of COVID-19 and 2 times than that of influenza. So these viruses don't have pandemic potential. They are not going to cause a respiratory surge. But if you are elderly or if you are immunocompromised host do land up on a ventilator, then the risk of invasive mechanical ventilation is higher than COVID-19 and higher than influenza. So the clinical presentation is simple, more or less like HMPV only. Majority of the patients having just cough cold symptoms, but can progress to acute respiratory distress, especially those with COPD or congestive heart failure, and elderly patients can fall prey to symptomatic RSV illness. Pulmonary disease, as I said, is more common in patients with comorbidities or in patients with hematopoietic stem cell transplant. So again, the same. Whatever happens in human metapneumovirus happens in respiratory syncytial virus as well. If you have hematopoietic stem cell transplant, if you have had a kidney transplant, if you have a lung transplant, if you have COPD, asthma, coronary artery disease, then you can have upper respiratory tract infection of RSV progressing to lower respiratory tract illness, pneumonia, ARDS, and can land upon invasive mechanical ventilation. RSV has a peculiar thing of flaring up your cardiac illness as well. So those patients who already have congestive heart failure can lead to arrhythmias, acute coronary syndrome, myocarditis, and also sometimes patients who have no cardiac illness can also land up with congestive cardiac failure. So this is what is different for respiratory syncytial virus as compared to human metapneumovirus, and we should be aware if the patient, which I have already said, lands up on a ventilator. Again, imaging is not specific. It can mimic any other viral pneumonia. As you can see, ground glass opacities, reticulations, all this can occur. Consolidations can occur, and hence it is very difficult to differentiate what is the etiologic agent. And in India, there has been a feature that once the patient lands up on a ventilator, is diagnosed to have viral pneumonia, we only test for COVID-19 and H1N1. If both come negative, we just label it as viral pneumonia, COVID negative, H1N1 negative. Remember, these two viruses, respiratory syncytial virus, human metapneumovirus, and also rhinovirus are the causative agents of these viral pneumonias which come as H1N1 and COVID-19 negative. And now it is time that we also identify the etiology of these COVID and H1N1 negative viral pneumonias. As I said, mortality is only 1% overall, but if you are hospitalized, then the mortality can be 2.5%, and mortality appears to be higher than that of influenza. So it's a bigger killer than H1N1. And especially if you are having hematopoietic stem cell transplant or any other stem transplant, in hematopoietic stem cell transplant recipients, those who develop LRTI, the mortality can be as high as 80% because of severe respiratory syncytial virus involvement of the lower respiratory tract. In lung transplant recipients, the mortality can be as high as 20%. So it's a very big killer, a bigger killer than human metapneumovirus, and sometimes a bigger killer than H1N1 as well. Gladly, it does not have pandemic potential, and more or less we have immunity against this virus because it is a virus of the children to start off. Diagnosis again is only because of RT-PCR and the multiplex PCR panel, which I said, BioFire test does detect respiratory syncytial virus as well, and it should be done for almost all patients. It is done in the US and Europe, but in India, at least in immunocompromised adults, like hematopoietic stem cell transplant recipients, like lung transplant recipients, we should be doing for them at least this targeted RT-PCR testing should be done so that we can identify these patients. Treatment more or less is symptomatic. However, in transplant recipients, combination therapy of ribavirin and immunoglobulin IVIG does work. High titer RSV immunoglobulin is available in the states, but it's not available in low and middle income countries. But ribavirin and IVIG is sufficient for treating respiratory syncytial virus pneumonia as well. In the states, they also have vaccination against respiratory syncytial virus, and there is a recommendation that everybody above 75 years of age and everybody above 60 with either cardiac or pulmonary involvement should take at least once a respiratory syncytial virus adjuvanted vaccine, because this vaccine is going to prevent flares because of respiratory syncytial virus and also is going to give certain amount of cross protection to human metapneumovirus because it is a sister virus. So in the West, already there is a move towards, and in July 2024, this was the updated recommendation that everybody above 60 with or without comorbidities should take yearly at least once respiratory syncytial virus vaccine. And if this comes into low and middle income countries, we might be able to tackle these two viruses as well. There is also a global trial to make vaccine for both these viruses, human metapneumovirus and respiratory syncytial virus together, so that we can tackle these viral illnesses once and for all. This is just the latest paper of clinical feature difference. I just want to point out that how to differentiate between human metapneumovirus and respiratory syncytial virus. Human metapneumovirus has more fever, more cough, more dyspnea, more retractions, more wheezing, because it is more involvement of the bronchioles and the bronchi, while consolidation is more in respiratory syncytial virus. And adults also, it is more or less the same. However, you can see the severe infections in children is more or less the same with human metapneumovirus and respiratory syncytial virus, but in adults, respiratory syncytial virus, almost 10% or 18% of adults can get infected with RSV, elderly especially, transplant recipients, and they can land up with severe pneumonia. And the severity of bacterial pneumonia is 3.5 times that of human metapneumovirus pneumonia, and RSV pneumonia severity is almost 2 times that of human metapneumovirus pneumonia. So human metapneumovirus is not a dangerous virus. Very rarely it is going to cause pneumonia. Most of the times it is going to cause bronchiolitis, but the sister respiratory syncytial virus, especially in adults, elderly adults, where they are not vaccinated, can land up with severe viral pneumonia. Of course, it is not as severe as bacterial pneumonia. So in conclusion, human metapneumovirus was discovered in 2001, but it is already there from 60 years. It transmits because of close contact and large droplet infections. Majority of the time it presents with only viral upper respiratory tract, mild self-limiting illness. In only a minority of patients, that means premature children, adults more than 65, and transplant recipients, it can progress to bronchiolitis, asthma, severe pneumonia, or ARDS. Currently, only the BioFire film array respiratory panel assay for both upper respiratory tract and lower respiratory tract are cleared by US FDA for testing this virus. And majority of the times, the treatment is supportive, while very rarely antiviral therapy is needed. What about conclusions in respiratory syncytial virus? It is much more significant pathogen for adults, especially elderly and transplant recipients. In children, it causes majority of the time upper respiratory tract. As I said, majority of the patients also in respiratory syncytial virus develop viral upper respiratory tract illness. But if you have cardiac problems, if you have respiratory problems, if you are a smoker, if you have interstitial lung disease, then respiratory syncytial virus does cause lower respiratory tract involvement, where the mortality can be as high as 80% in hematopoietic stem cell transplant. Again, diagnosis is only by BioFire film array respiratory panel assay. Treatment, however, is ribavirin and immunoglobulin for severe viral pneumonia, and there is a vaccine available where in the West, everybody above 60 years of age is encouraged to get the respiratory syncytial virus vaccine, which offers some amount of cross protection to human metapneumovirus as well. And there is globally a need for a vaccine for both respiratory syncytial virus and human metapneumovirus, which we can give to all our elderly, even in low and middle income countries, so that we can protect them against these deadly diseases. Thank you, and I'll stop sharing and take whatever questions come my way.
Thank you so much, Dr. Ameet. This was a very good session and a very relieving session for us to understand what's going on in the world. We are now opening the floor for the question answers. Please,
Saurabh, can I
please
say?
go ahead, Dr. Sajjad.
I'm sorry. It was excellent, informative presentation. I remember Ameet Dravid with the name of a legend cricketer, Rahul Dravid. He was very talented cricketer. So excellent presentation, Ameet. I have a lot of knowledge. I am an ENT surgeon, and nowadays we are having in Karachi a lot of cases of this upper respiratory tract infection. So my question is, I have written some questions, but you have already mentioned the answer I have given. But my question is why it has happened in the month of December, January, or I can say why it is happening in the winter, the viruses, why it's so aggressive. Number one. Number two is you said there the about the vaccine that it's still is working on for vaccine of human metapneumovirus. But can the COVID virus, which we have already, can help this virus to protect? Thirdly, you said imaging for diagnosis. Can X-ray, simple X-ray, chest, PA view, can help for these patients? And lastly, my comment is that these patients should be advised to improve their immunity so that they can protect themselves from these viruses, including the good diet, the life change of lifestyle, like the good sleep in the night and the exercise or walk, whatever it is. This is my comment. Thank you very much.
Yeah. Thank you, Dr. Kesar, and I'll take your questions one by one. So why now? So see, these respiratory viruses are temperature dependent viruses. They require cold to set in before they can cause upper respiratory tract infection or lower respiratory tract infection. And as you know, there is a cold wave sweeping through India, and I'm sure it is sweeping through Pakistan as well. So that's why January to March are the months when we have the maximum amount of cold in our countries. That is when these viruses flare up. And remember, there is a competition between viruses as well to demonstrate who is the big boss during particular months. So it has been shown year after year that in November and December, it's the influenza and the respiratory syncytial virus, which are the viruses which say that they are the big bosses. While in Jan, Feb, March, it is still influenza and respiratory syncytial virus, but human metapneumovirus also comes at third place and causes viral upper respiratory tract infection and LRTI. I forgot to mention from ENT point of view that these viruses, human metapneumovirus, can cause otitis media, can cause sinusitis, and hence you can get patients with viral sinusitis, viral otitis media, which you might need to tackle in your OPDs as well. Secondly, I think the X-ray is not going to be helpful because what I feel is almost majority, 99% of patients are going to have just upper respiratory tract infection. They are going to require only symptomatic treatment. They are not going to require antiviral. So we actually might not need an X-ray, might not even need an HRCT as well. Very, very few children who are born premature or elderly who have weak immunity are going to come to us, and majority of the symptoms are going to be bronchiolitis, which might not be picked up on X-ray because pneumonia incidence in human metapneumovirus is lesser than that of respiratory syncytial virus. So I feel that X-ray might not be helpful. We might be forced to go for a CT scan. And COVID, whether COVID will protect, I don't think so. But there have been studies in HIV infected patients where pneumococcal vaccine actually protected against gave some amount of protection against human metapneumovirus, because pneumococcus and human metapneumovirus can act together and cause either upper respiratory tract or lower respiratory tract involvement. So COVID-19 vaccination, no, but yes, pneumococcal vaccination to our elderly, and we anyway recommend that all our elderly patients should get pneumococcal vaccine. So that might help in to some extent in reducing the severity of human metapneumovirus.
Thank you very much, Ameet.
Thank you.
Thank you, Dr. Dravid. I see a lot of comments from Dr. Monica Vasudev coming in chat box. I would like to invite her for her opinion and suggestions and comments on the session. Dr. Monica.
Thank you, Saurabh, and thank you for this platform again. What a great way to start off the year for talking about a topic that Dr. Dravid has explained extremely well. Thank you for a wonderful presentation. And I agree with you that you took a topic that has started off on social media and has brought so many people a lot of worry. But the same lessons that we've learned from COVID and the pandemic is the same principles that we apply to any respiratory illness. And again, highlighting that we are not utilizing identification of what the viral infection is okay, because if you apply the same metrics of how to treat, then that's great. You know, hand washing, distancing, avoiding places when you're sick, asking people politely not to come and join a gathering if they're infectious, and transmission period is great. And then the nuances of understanding the extremes of age, the young and the older. I do say that all of these things are fantastic. I know that there was a case that was reported of a child who had needed a very significant respiratory support with an infection, but these are isolated cases. And I think that those get amplified on social media. And for every one person that's amplified, there'd be many, many more people who have the infection and they don't even know that they had the infection. So I think I would even add on like nasal saline rinses using things that we all know, time-tested, proven, things that our grandparents taught us are also ways to minimize infections. And then to be just, if there are concerns, to be vigilant for secondary pneumonia, making sure that that gets diagnosed, making sure that those who are at risk for being hypoxic are getting addressed. But I think that you touched on so many of these things. If you do come to the US, we do know that visitors can get immunizations. So like, I know that a lot of people who are coming and getting the Pfizer vaccines and the Moderna vaccines, and then when they were traveling to the US, similarly, if you want to get the RSV vaccine, just make sure you bring your documentation. Most of our commercial pharmacy locations will allow you to pay out of pocket for these vaccines. So definitely, if that is something that is on your agenda, make sure you get those vaccines sooner in your trip. So that in case you would like other vaccines, like the shingles vaccine, there's other vaccines that a lot of tourists get in the United States. Do your homework before you come to make sure that you can do that as well. But thank you again, Dr. Dravid, for a fantastic presentation.
Thank you, Dr. Monica. So do we have any other questions on the floor? Any comments? Dr. Andrik, Dr. Pillay, Dr. Hussain, anyone? Dr. Maria?
Dr. Pillay here. Is there any need for public health measures, particularly from the month of January to April or so, wearing masks, hand washing, distancing and all? And is there any need for genomic studies to find out whether any variants are coming which is more severe? Thank you.
Yeah. So as I said, social distancing and universal masking measures as of now in India are not needed, but there are going to be huge population congregations in India very soon. I think there is a Mahakumbh which is planned in January, where I think 40 crore people are going to come. That's what they say. If it's really that big a congregation, then if you are above 65 years of age or if you have severe comorbidity, I would suggest wearing a mask throughout your travels. The wedding season is coming up. There are huge weddings in India as of now going on right now. There, if you have above 65 and if you have a severe comorbidity, you should be wearing masks. But for the entire population, universal masking and universal social distancing as of now is not needed. Genomic studies, I think, are already underway in NIV Pune. And if we do have a respiratory surge because of human metapneumovirus, I'm sure we will be sending samples from even private clinics to National Institute of Virology Pune to do the genomic studies. But yes, if you are elderly, if you have comorbidities, and if you are sick, please don't venture out. If you do venture out, wear a mask.
Thank you.
Dr. Andrik, you were saying something?
Thank you. I just want to say thank you again. I have been asked by quite a few media stations to comment on this virus, and the research that I've done is exactly what Ameet had said. And actually, he's got much more information than I got. But yeah, I think there's an unnecessary hype from the media out there. And I think it is important to have this type of meetings that we have this morning to empower our doctors as to what is the real case. And again, I think the fact that it's not a new virus, that most of the globally people has been infected while they were under the age of 5 is the reason why we should not worry. And yes, it's like with any of the viral infections or upper respiratory tract infections, you use normally the term viral infection only when the patients really get sick and sent to hospital or require more intensive treatment that one starts to test, because it's not financially viable to test every patient coming into a normal surgery at primary healthcare level. But these types of lectures that we had this morning, extremely important, and thank you again for this. Thanks.
Dr. Dravid, just the last question we will take, and we'll close the session after this. This is probably on the Facebook. If you see, Delhi hasn't seen any cases till now. It's majorly in Jammu, Kashmir, Gujarat, and all these areas. But let's talk about the cities which are overpopulated and overpolluted.
Yeah.
So if you see, Delhi is having a very high rate of pollution, and it's almost touching more than 500, 600.
Yeah.
A lot of people are anyways coughing. So what is it, a differentiator for an old age person and even a young person who is coughing, who's traveled, have a travel history? How will they differentiate between the infection and a regular cough which is happening? And what are the first symptoms they should acknowledge, and what are the first steps they should do?
Yeah.
And where is the point of worry? Yeah.
See, Delhi has not reported any cases. That is because maybe we are not testing more. As I said, the West tests much more than us, and that's why they can put out these statistics. I'm sure if we start testing all our acute respiratory infections, we will find many more RSVs, many more human metapneumovirus, many more rhinovirus, many more influenza. So we are underreporting because we are not testing much. It is very difficult for us to differentiate from symptoms, who suffers from common flu and who suffers from human metapneumovirus. And actually for young patients, it is entirely an academic exercise because the treatment is going to remain the same. If you have fever, cough, cold, sore throat, laryngitis, pharyngitis, please visit a doctor. The doctor is going to give you routine treatments which he gives for common flu, like paracetamol, like nasal decongestants. Sometimes if you have wheezing or asthma, they might try bronchodilators. They might sometimes try steroid bronchodilators for helping with your bronchiolitis. That is going to help. And that is why it's an academic exercise. We don't need to get into it. Yes, if you are elderly, you are coughing, you are having pneumonia, you are hospitalized, that is the time when we should be really testing for these viruses. And that's why I always felt that putting out numbers that today we have our 8th case of human metapneumovirus, today we have our 9th case of human metapneumovirus is actually useless. We should be putting out numbers of these viruses causing severe infections. Only those are the infections which are going to actually help us as of now. We are not in that situation where we can test everyone, but at least all our acute respiratory infections which land up in the hospital should be tested for all the viral etiologies which I have mentioned as of now.
And people who are taking self-medication like, steam inhalation, Vicks, and, in nebulizer or probably cough syrups to suppress the cough, will that help, or will that increase the problem if they don't visit the doctor?
Ideally, I think a visit to a doctor is always warranted. Self-medication, as we have seen with many of other viral illnesses, leads to problems. But the main thing comes at that we have to maintain good respiratory health. And unfortunately in Delhi, because of the pollution, it is very difficult for people to maintain good respiratory health. And there, if you are universally masking residents of Delhi, I would not have a problem, because of the pollution can also worsen these symptoms. So there, if you are using universal masking, it's fine. But self-medication, I would still venture against it.
Okay. Dr. Naidu, do you have any questions?
No questions, please.
Perfect. So I think with this note, we'll take a closure for this session. It was a very nice and interactive session. I think the first session of the year brings a lot of knowledge to us. We'll bring more sessions and more speakers for this. With this note, I would like to thank everyone and wish you all a very happy New Year once again.
Happy New Year.
Thank you. Happy New Year.
Thank you. Happy New Year.
Thank you. Happy New Year.
Hare Krishna, Hare Krishna.